Today we are going to discuss about the treatment of prognosis and determination of prognosis and treatment plan. So, what do you understand by prognosis? Prognosis is a prediction of a course, duration, outcome of a disease based on the pathogenesis of the disease and presence of risk factors associated with the disease. So we are going to assess the how the disease should be progressed, and it is based on the general knowledge of the pathogenesis of the disease. So what happens? Prognosis is directly established after the diagnosis and before the treatment plan. So you are going to assess the prognosis, overall prognosis or individual to prognosis, and it is always determined after the diagnosis is made. Then what are the various types of prognosis? Various types of prognosis: the excellent prognosis, good prognosis, fair prognosis, poor prognosis, and questionable prognosis. So basically, there are 5 types of prognosis. So what do you understand by which group of patients and come under the excellent prognosis? Excellent prognosis includes there should be no bone loss or there should be minimal bone loss with excellent gingival and periodontal condition. What do you understand by excellent gingival and periodontal condition? Means the color, all the factors which we are assessing for the to check the gingival condition, like color, contour, consistency. Color should be pale pink or coral pink with the melanin pigmentation. There should not be any reddish discoloration, and there should not be any changes in the consistency. They should be firm and resilient, not soft and edematous or not fibrous consistency. And there no should be the gingival margin should be scalloped and knife edge. And all the gingival condition, there will be no presence of bleeding, no like pus suppuration or exudate suppuration. There will be no enlargement. Then it will come under the excellent gingival condition. Good patient cooperation. Patient is very cooperative and patient is very hopeful about the treatment. No systemic and environmental factors, means there should be no environmental factors. Environmental factors like the presence of smoking, like patient is working in that area, like the patient is working on the mining and all those things. Then this also come under the environmental factors. And systemic factors includes the presence of systemic diseases. Systemic diseases means like anything, diabetes, cardiovascular diseases, and presence of any systemic factors. And now about the good prognosis. So all these factors come under the excellent prognosis. Now the good prognosis means there should be one or more of the following. Means there should be adequate remaining bone support. If there is like etiological factors present, there is adequate or every chance to possible that to control that etiological factors. And to establish a maintainable dentition, there should be adequate patient cooperation. There should be no systemic environmental factors, and if they are present, they should be well controlled. So, what do you understand by good prognosis? The remaining bone support means like the patient is having a bone loss, it is minimal, and even the like the 2 to 3 millimeter bone loss, sometimes like the attachment which has been left is enough to support a tooth. So there should be no mobility. Adequate remaining bone support means there should be no mobility in spite of being bone loss. And there should be any etiological factors, means like there is malocclusion, you can correct malocclusion. And if there are overhanging restoration, you are going to control the overhanging restorations. So these are the like controlled etiological factors. Now about the third prognosis, we have discussed about the good prognosis and excellent prognosis. Now about the fair prognosis. Fair prognosis means one or more of the following, means less than adequate remaining bone support. There should be some tooth mobility and some bone loss, which includes grade 1 furcation involvement, but the adequate maintenance is possible, acceptable patient cooperation is there, and presence of limited systemic and environmental factors. So fair prognosis, which includes means that there is adequate remaining bone support, there can be mobility grade 1, and that there is bone loss, so there will be grade furcation involvement, but what happens when the thorough scaling, route planning, professional mechanical plaque control, there should be a proper maintenance is possible with the use of all interproximal dental aids you can use, and patient is very cooperative. And if the mild diabetes patient has suffered from the mild systemic disorders, but they're also well controlled. So this is fair prognosis. Now, what understand by the patients are categorized into the poor prognosis. So what happened? There is bone loss, which is the severe bone loss. Sometimes like mild, moderate to advanced bone loss. There will be tooth mobility, and there will be involvement of the percussion areas, grade 1 and grade 2, and difficult to maintain areas or doubtful patient cooperation and presence of systemic and environmental factors. So, which means the grade 1 and grade 2 percussion involvement. Grade 2 percussion involvement, as you all know, the bone is like attached to the dome of percussion, but there is horizontal loss of the horizontal loss component of the bone has been lost. So, there will be produced they produce the inaccessible areas which is difficult to maintain or clean. Okay, then what happened? There should be some tooth mobility also, and there the presence of risk factors are also there. So questionable prognosis. So what do you understand by questionable prognosis? There will be bone loss, there will be more than grade 2 percussion involvement, like grade 3, grade 4 percussion involvement, there will be tooth mobility, and there are a lot of inaccessible areas which cannot be assessed by the normal cleansing mechanism, and the presence of the systemic and environmental factors. So provisional prognosis, basically it allows the clinician to initiate the treatment of teeth that have doubtful outlook in the hope that a favorable response may tip the balance and allow teeth to be retained. So what do you understand that for the questionable prognosis, there are a lot of inaccessible areas and the presence of systemic factors that cannot be controlled. So by the all the category, you can make a provisional prognosis. So you can initiate the treatment at least in a doubtful patient, and if you are accepting a favorable response, so you can decide which tooth has to be extracted, and you can follow the treatment plan. You can make the treatment plan according to the categorization of prognosis. So what happens? Which all factors helps in the determination of the prognosis. So basically, there are two factors. There are to determine the prognosis. First is overall prognosis and individual tooth prognosis. So for the overall prognosis, you are going to assess overall clinical factors, which includes patient age, patient severity, plaque control, and patient compliance. So this is the major components. You are going to assess about the patient age and how the disease is, how you can categorize the disease into the mild, moderate, and severe, and how the patient is going to maintain the plaque after the for the all the periodontal disease. Plaque is a etiological factor. You all know that the plaque is a primary etiological factor for the periodontal disease. So even after the periodontal surgical procedure, if patient is not maintaining, is not patient the proper protocol, so what happens sometimes it is a responsibility of the doctor to make understand the importance of oral hygiene and how to maintain the oral hygiene in that area. So these are the overall clinical factors and systemic environmental factors, which includes the smoking, systemic disease, condition, genetic factors, and stress. These are the systemic factors you need to see. These are the environmental presence of smoking, systemic disease and conditions, genetic factors, and stress. Local factors, you're going to see about the plaque, calculus, presence of subgingival restorations, anatomic factors which include short tapered roots, cervical enamel projections, enamel pearls, bifurcation ridges, root concavities, developmental grooves, root proximity, percussion involvement, and tooth mobility. These are the local factors. And now the fourth one is prosthetic and restorative factors, which includes the selection of abutment tooth, caries, presence of non-vital tooth, and root resorption. So these are the basically four factors on which we can determine the prognosis. Overall clinical factors, systemic and environmental factors, local factors, prosthetic and restorative factors. So overall factors includes, now we are going to describe in detail on this the page you can determine the prognosis. Now first is your patient age. Patient age is like very important in determining the prognosis. Like for the two patients, if you compare the level of attachment loss and level of remaining connective tissue attachment, so prognosis will be better for the individual who is older. Why? Because first of all, in your mind that it comes like that, patients with a younger age has will be more favorable prognosis as compared to older age. But like consider a patient, one is young age, one is of old age, and both have the like 5 millimeter of clinical attachment loss. So what happened? Prognosis will be better for the older individual. Why? Because here we are not going to decide just on the patient age. We are going to decide the prognosis of individual tooth based on the destruction, the rate of the destruction of the periodontal disease. So you can see how to everything we want to calculate. So the rate of destruction of the periodontal disease, basically the 5 millimeter has been destroyed periodontium in a such a short duration of time, in a such a, like for the younger individual, let's consider 30 of year of age. So it took 5 millimeter of clinical attachment loss for in a 30-year-old patient, and 5 millimeter of clinical attachment loss in a 50-year-old patient. So you can find out the rate of disruption is higher in younger individual as compared to the older individual. So the prognosis will be favorable for the older individual. As for the younger patient, the prognosis is not as good because the shorter time frame in which the periodontal destruction has occurred, because the younger patient suffers from an aggressive type of periodontitis, or disease progression may have increased due to systemic disease or smoking. So the reason is explained, the shorter time frame, and there can be the causes. Patient has suffered from the aggressive periodontal disease in which affects the younger individual, and also the presence of some risk factors like smoking. And now the third point, the younger patient would be expected to have a greater reparative capacity. The occurrence of much destruction in a short period exceed any naturally occurring periodontal repair. So what happened? The younger patient, they basically have more capacity to heal, more immunity is there. So but what happened? The rate of the destruction is faster than the rate of the repair. So and so this much damage has done, means the damage, the rate of the destruction is obviously faster than the rate of the periodontal repair. So for three criteria, the older individual has favorable prognosis as compared to the younger individual for the same amount of destruction. Now about the disease severity. Disease severity means you are going to assess the disease severity. How you can assess? By the soft tissue attachment loss and by the hard tissue attachment loss. So by the clinical attachment loss and periodontal probing pocket depth. So what happened? The determination of the level of clinical attachment reveals the approximate extent of the root surface that is devoid of the periodontal ligament. The radiographic examination shows amount of root surface is still invested in bone. Pocket depth is less important than the level of attachment because it is not necessarily related to bone loss. In general, a tooth with the deep pockets and little attachment and bone loss has better prognosis than one with the shallow pockets and severe attachment and bone loss. The prognosis can be also related to height of remaining bone. So what happened? Which criteria you are going to assess for the disease severity? Pocket depth is less important because of the clinical attachment loss, because a tooth has a deep pocket and a little attachment loss has better prognosis with the shallow pockets and severe attachment loss. So we consider the clinical attachment loss as a gold standard for measuring the disease severity. If it is directly proportional to the prognosis. More clinical attachment loss, the prognosis will be poor. And the more basically it is not directly proportional, it is inversely proportional. The severe, as the connective tissue attachment loss, clinical attachment loss increases, prognosis will be unfavorable. And the clinical attachment losses is small or less, the prognosis will be favorable. So prognosis basically it depends upon the disease severity. If the disease severe, if the is it is directly proportional to the disease severe. So disease is severe, then prognosis will be unfavorable. And if the disease is like starting, that is mild disease, then the prognosis will be favorable. So it can be assessed directly related to the height of remaining bone. So what happened? The type of defect also, it should be determined for assessing the bone loss and for assessing the overall and individual tooth prognosis. So what happened? So you are going to assess the type of the defect, whether the defect is horizontal or vertical. So in case of angular and intra-bony defect, the contour of existing bone and number of osseous wall are favorable. Then there is excellent chance that therapy could regenerate bone to approximately the level of alveolar crest. What happened? Angular bony defect means there is a V-shaped defect adjacent to the bone. So if the number of osseous wall is favorable, so you can categorize the osseous wall defects into one wall defect, two wall defect, three wall defect, or it can be circumferential defect, crater defect, ledges, all those things. So you are going to categorize this intra-bony defect. So the number of walls present basically determine the regeneration therapy it can be done. So one wall defect means one wall is present. So you are not going to provide the any regenerative therapy. You are not going to attempt the regenerative therapy. So prognosis will be unfavorable. But for the two wall defect means two wall is present and two wall is lost. Means like for example, buccal and lingual wall is present and nasal and distal wall is absent. And for the three wall defect, three wall is present and one wall is absent. So three wall defect is the most favorable for the attempt to regeneration of bone. So if there is three wall defect, in case of vertical or angular bone defect, three wall defect has a better prognosis as compared to one wall defect. So again, when a greater bone loss has occurred on the one surface of the bone height on less involved surface should be taken into consideration when determining the prognosis. So you can find it out when the bone loss is more, the prognosis will be unfavorable. But you have also seen the type of defect, like three wall defect has a better prognosis as compared to one wall and two wall defect. So two things you have to assess, the horizontal bone loss or vertical bone loss, or you can assess the type of the defect. See, here you can see the amount of bone loss in the first case, like for the mesial wall, and the bone loss is more in case of A, there will be more bone present and there is horizontal bone loss. And in this case, there is vertical bone loss. So you are going to assess the center of rotation. So the center of rotation for the A it is nearer to the crown. So basically there can be more favorable distribution of the forces. There should be less jiggling forces, less stopping forces. So the prognosis of A will be better than prognosis of B. Now the third point we are going to discuss, that is plaque control. So bacterial plaque is a primary etiological factor associated with the periodontal disease. So therefore, effective removal of plaque on daily basis by the patient is critical to the success of periodontal therapy and prognosis. If the patient is maintaining plaque control, then the prognosis will be favorable. And if the patient is not maintaining the plaque, then prognosis will be unfavorable. Like for as compared for the two patients, both patients have undergone periodontal flap surgical procedure, have the same amount of bone loss and presence of no systemic factors and everything, and even the risk factors which are associated can be easily controlled. But the patient who is maintaining has favorable prognosis as compared to patient who is not maintained, because again patient plaque, if there is plaque deposition, again there is sequence of events that can lead to periodontal disease. Now the third point is patient's cooperation and compliance. See, this is very important point. You can assess after the diagnosis the prognosis of the tooth, but you are going to see the patient's gingival and periodontal condition, and you can decide which tooth has to be retained, which tooth has to be extracted. But patient should have like a strong willingness to retain the natural teeth and should have strong willingness to maintain the good oral hygiene, because without this the treatment cannot be succeed. Okay, so the dentist can refuse to accept the patient for such treatment and extract the teeth that are hopeless and poor prognosis, and should perform scaling and root planning on the remaining teeth. So patient compliance is very necessary, because patient should maintain the natural teeth and have should willingness to ability to maintain the good plaque control. Now about the second point, we have discussed the first points, overall clinical factors, the patient's age, disease severity, plaque control, and patient compliance and patient's cooperation. Now the second point is your systemic diseases and environmental factors. So patients should inform that smoking affects not only severity of periodontal destruction, but also healing potential of periodontal tissues. As a result, patients who don't smoke respond well to the conventional periodontal therapy, and who smoke the periodontal conventional therapy is not responding. Therefore, prognosis in such a patient who smoke have slight to moderate periodontitis is generally fair to poor. And in patient with the severe periodontitis, the prognosis may be poor to hopeless. See, there should be like downward reporting of prognosis. Like if we consider patient for the fair prognosis, but patient smokes, ultimately it is poor prognosis. And if patient categorized into the poor prognosis, so you are going to consider the patient, if the patient smokes, for the hopeless and questionable prognosis, because smoking has a lot of effect on the periodontal destruction, and presence of smoking increases the risk of periodontal infection, and there is also the presence of inflammation, and even the for such type of periodontitis, patient does not respond to the treatment. Yeah, like you're performing the full medical checkup, and you are going to do professional mechanical plaque control, you are going to give antibiotic and everything, but patient does not respond. So this is also known as refractory periodontitis, means patient is not responding